Let's move to our presentation, case presentation. And I would like to invite Dr. Maria Karaflou to present our first case. Maria is an endocrinologist practicing in Athens, Greece. She holds a master's degree on metabolic bone disease and a PhD on reproductive endocrinology from Athens University Medical School. She had her specialty training in Oxford University Hospital and in St. George's Hospital in London. Maria is an active member of the European Menopause and Andropause Society, and she has recently published her work about menopause and public policy. Maria.
Good evening. Thank you very much for the invitation and the kind introduction. I'm very honored to present the following clinical case tonight. A 39-year-old woman with autoimmune thyroiditis, cycle irregularity, and joint pain. I have no conflict of interest to disclose. A 39-year-old woman with history of autoimmune thyroiditis presents to the clinic with symptoms of irregular periods and joint pain. Her periods have lost the regular pattern of 20 days over the last 5 years. Her periods are now irregular, with the duration varying from 20 days to 40 days. She had one skipped period 3 months ago. Hot flashes and night sweating are now a problem. Muscle and joint pain, especially at her fingers, have been bothering her. Sleep disturbance with early awakening is another symptom. She is also complaining of decreased sexual desire. She gets easily upset. She had one episode of urinary tract infection 1 year ago. She has also been complaining of increased weight over the last 2 years. Her drug history: she has been receiving levothyroxine 50 micrograms per day. She has no known allergies to medications. Gynecological history: her menarche was at the age 11. She had regular periods of 28 days in terms of duration until the age 34. Initially, at age 35, her periods became shorter and periods presented every 24 days. Later, in this 5-year time frame, periods have been irregular, either shorter than 21 days or longer than 35 days. She skipped one period 3 months ago. She had no pregnancies in the past and she's not willing to get pregnant. In terms of family history, her mother had vitiligo and autoimmune thyroiditis. Her mother had her last period at age 44. Her family history is negative for breast cancer and negative for thromboembolic events at a young age. In terms of the physical examination, she had a blood pressure of 120/80 millimeters of hydrogen and 75 beats per minute. Normal heart sounds on auscultation of the heart. We have performed body composition analysis in the clinic and her BMI has been 23.6 kilograms per square meter. In terms of her body composition, the skeletal muscle is within normal limits. The fat mass is right above the upper limit of normal, 21.1 kilograms. And her abdominal fat has been increased. It is 10.8 kilograms, and this is actually twice the upper limit of normal. Of course, we have requested a pregnancy test that was negative, and there have been blood tests. Her glucose was 104 in the morning with an insulin of 6.7 micro-IU per ml. TSH is normal, 1.9 micro units per ml. This is actually an indication that she has been receiving the right dose of levothyroxine. We can see in the slide that her FSH has been very high. It is 132.8 micro-IU per ml. Estradiol levels are really low, 10.1 picogram per ml. We have also requested anti-Müllerian hormone. It is severely low, 0.1 nanogram per ml, and karyotype has been of normal female. So, the diagnosis has been premature ovarian insufficiency, as she is less than 40 years of age. High FSH and LH with low estradiol confirm the ovarian insufficiency. Low anti-Müllerian hormone indicates decreased ovarian reserve. Normal karyotype excludes Turner syndrome or other chromosomic anomalies. We have requested a thrombophilia screening test. This is negative, and breast images have also been negative. So, it seems that this woman has autoimmunity-related premature ovarian insufficiency. In terms of management, of course, we had to start menopausal hormone therapy. In this case, this is hormone replacement therapy with estrogen patches continuously plus progesterone pill for 12 days per month to induce a cycle of 28 days in duration. Of course, our goal is to re-establish the menstrual rhythm and to mimic physiology. We also have the goal to relieve menopausal symptoms. We have requested DEXA scan and we're going to monitor bone density. We have also requested a visit of hers to the cardiologist. Of course, this young woman has to follow some lifestyle advice in terms of diet. We know from the publications of the European Menopause and Andropause Society that Mediterranean diet and Asian diet as plant-based types of diet are indicated. She has to follow exercise, physical exercise with resistance type of exercise, and of course stress management. This young woman has come back to the clinic 3 months later. She feels much better. She has established cyclicity of 20 days duration of the periods. Joint pain has completely resolved. This is actually an indication that the arthralgia was related to menopause. She has a much better quality of sleep and there have been no episodes of urinary tract infection or vaginal secretions. So, this 39-year-old woman with primary ovarian insufficiency linked to autoimmune thyroiditis has started menopausal hormone therapy successfully, and this case highlights the need for early detection and management of autoimmunity-related ovarian aging. Thank you very much for your attention.
Thank you very much, Maria. Thank you for your presentation. And I can see here that we have a couple of questions. There is one question related to the previous speaker, but I suggest that we finish with the question related to our case and then come back to the anon fezolinetant. So the first one is from Dr. Massoud. Is it really important to do a karyotype in a woman who has normal menarche and normal periods until the age of 35 years? So a woman approaching the age of 40?
Well, actually, I think we have to follow the guidelines. If there was no karyotype or if you were in a clinical setting with no available karyotype testing, then it wouldn't be necessary. But because of your young age, we have to exclude the monosomic Turner chromosomic anomaly. Of course, in Greece, this test is easily available, and this is why we have performed the karyotype. But I understand that this is a rational question. And actually, I can also see a second part of this question. Is it routine for FSH to be higher than LH in the perimenopause? Well, actually, FSH is a better indication of the menopausal status of a woman. This is supported by the publications, and we need an FSH more than 25 to get the indication of the premature ovarian insufficiency. Most of the times, FSH is a stronger indicator. LH is following FSH. So it is, I think most of the times FSH is higher than LH, but FSH has a stronger capacity to
Yeah,
lead to the diagnosis.
sure. And if I may add, I will mention the talk of Dr. Panay yesterday, that even in the age group of 35 to 40, we made detect some mosaics of Turner syndrome. So it's not irrational to perform karyotype at that age. So,
Yes, of course. And actually, what I forgot to mention is that the ESRE, the most recent guidelines from ESRE on premature ovarian insufficiency, say that we should check antibodies against the adrenals. So we should check 21 hydroxylase antibodies, and also the antibodies against thyroid disease. So in this case, of course, she had autoimmune thyroiditis, and she had positive anti-TG and anti-TPO antibodies. What we didn't do is the anti-21 alpha hydroxylase antibodies, because they are not easily available in our country, but the guidelines say that we should
mhm.
test them as well.
So another issue is how do you prevent pregnancy in these women? Because spontaneous pregnancies sometimes, occasionally could occur. And do you prescribe them with HRT, or do you prescribe oral contraceptives?
Of course, at this young age, I think that oral contraceptives would be an acceptable measure. In this case, she got the advice to place a copper
Mhm.
intrauterine device, because we wanted to be not that aggressive with the doses of estrogen. And that was her personal opinion as well. She got the information and she decided to follow the regime of the patches, estradiol patches plus progesterone for 12 days per month. So it was
Okay,
her decision as well.
okay. So do you see often the coexistence of autoimmune thyroiditis with premature ovarian insufficiency?
Well, actually, I think that this is a pretty common scenario, especially in Greece. We know that autoimmune thyroiditis is a very common condition, and autoimmune thyroiditis is easily present in women in the same families. We can see in this case that the patient's mother had an early menopause at the age 44, so her mother didn't have premature ovarian insufficiency, but she had an early menopause as well. And I can say that in clinical setting, we often see um, autoimmunity related premature ovarian insufficiency.
So thank you, Maria. And the last question for Alex. Can we prescribe fezolinetant in women older age, say over 65?
Um, at the moment, it's the answer is that it is licensed for postmenopausal women with moderate to severe hot flushes. So there's no age criteria. However, the studies have actually not gone above 65. So that's a very important question, actually, in the safety of these drugs in women over 65. And as you know, about 10% of women over the age of 60 still have hot flushes. 5% of women above the age of 70 still have hot flushes. So we don't have data in those cohorts as yet.
Thank you.